So thank you again for the invitation. We'll continue the topic of the management of colorectal metastasis. This next lecture will be something that's important to the group, which is how to manage synchronous colorectal, primary, and liver metastasis in the resectable patient. These are often topics that are perhaps the most controversial and almost enjoyable to discuss at multidisciplinary conferences. And this will be we'll talk about liver first resection, the so-called reverse strategy, something one doesn't typically think about doing the liver resection prior to the primary colorectal resection. Let's start with a case presentation to illustrate this. So this is a 59-year-old salesman who presents with change in bowel habits, colonoscopy, rectal cancer, 3 centimeters in diameter, 8 centimeters from the anal verge, MRI scan T3N1, CT reveals 2 liver metastases, CEA is elevated, PET scan shows uptake in the primary rectum and the 2 sites in the liver, otherwise healthy individual. Here is the studies, the primary cancer in the mid to upper rectum and 2 metastatic deposits in the right hemiliver. So how should this patient be managed? Potentially curative. We've just heard the resectable patient. This looks like a resectable patient in the liver. Primary rectal cancer. How should we manage this? Well, as you know, as we've been talking about, stage 4 colorectal cancer is a common scenario, much as this patient presents. 20% of patients present with stage 4 at the time of diagnosis. In spite of advances in screening, we still see many patients with advanced disease. Rectal cancer, as you know, about 30%. Colon is about 70%. Synchronous is being seen with increasing frequency by the hepatic surgeon and by the colorectal surgeon. So when one thinks about synchronous presentation, the first question one must ask in patients with stage 4 disease is, are they potentially curative intent? That is the disease resectable? And of course, many patients present with disseminated metastatic disease in which the colorectal surgeon or general surgeon is faced with a question of the role and timing of the palliative colectomy or proctectomy. This is a different scenario, so we won't be speaking about this because this is a patient where it's potentially curative, resectable metastatic disease. So in such a case, we all agree upon that this patient needs a liver resection. This patient needs resection of the primary tumor. This patient needs chemotherapy, most agree with that. And in the case of rectal cancer, as in this case, chemoradiation in selected cases. So this is the recipe. This is what the patient needs. The question then is, what is the optimal sequencing? And I tell patients it probably, in many cases, it doesn't really matter what the optimal sequencing, and one needs to individualize a strategy in order to achieve all of this. So what are the options in a patient? Well, let's talk about the patient who presents with resectable metastatic disease and colon cancer. Well, we could do the colon, then the liver, then chemo. We could do chemo, then the colon, then the liver, then more chemo. We can do chemo, then the colon, then more chemo prior to the liver in this sequence. Or we can do the colon and the liver combined with chemotherapy after. Or we can do chemo and the colon and liver combined with more chemo. You can see the scenarios keep going and going. And I can tell you that with rectal cancer, it's even more complicated because now we're thinking, should we introduce chemoradiation into? So you can imagine the fun we can have at conference presenting all the potential scenarios. And really the question is, what is the optimal sequencing? Today we'll focus on the reverse strategy, if you will, the liver prior to the chemotherapy. So first the questions when one thinks about the synchronous management, do the asymptomatic primary tumors need to be removed early? And that's an area of controversy. How should the symptomatic primary be factored into the decision of synchronous versus staged resections? What about the role of chemotherapy prior to colon surgery or prior to liver surgery? And how do we integrate radiation in the management? So you can imagine this is a complicated management algorithm. So and one can think about, when one thinks about whether to do the two operations, the colon and the liver together, one can think about various oncologic and practical factors. For example, what about the incision and the exposure? We'll talk about next minimally invasive liver surgery, but what if we want to proceed with a minimally invasive colorectal colon operation and a subcostal incision? You can imagine what about, it depends really on the complexity of the primary colorectal operation and the complexity of the liver operation as to whether to do a combination or staged approaches. What are the risks and what about the expertise? It may be that that there may be different hospitals or different availability of the experienced colorectal surgeon and perhaps the experienced hepatic surgeon. I must say there's an increasing trend in the United States and worldwide to perform these operations in one operation. And certainly the quality of life studies suggest that a combined colon and liver operation is favorable in most situations, but this needs to be temporized. We're going to focus on this more uncommon strategy, which is the reverse strategy. So as I mentioned, what is the best approach? Should we do the colon first, then the liver surgically? We call it kind of the classic strategy. Should we do the simultaneous resection, as I've just spoken about? Or what about the reverse strategy, the liver first strategy? And certainly we'll focus on that. It certainly has some appeal and perhaps some rationale. For example, it may offer earlier therapy for the metastatic disease. Some would argue the thing that will get the patient in trouble sooner. The treatment of the metastatic disease is not delayed by local therapy of the primary tumor or by complications of the surgical therapy. So one can imagine that if one starts with a colon operation, particularly if there are complications, that will delay the chemotherapy and delay the surgical management of the liver metastases. Primary-related complications are rare with stage 4 cancer receiving combination chemotherapy, so we can certainly consider this approach. We typically do the reverse strategy in rectal cancer, not colon cancer. So primary colon cancer with resectable metastasis, in most cases we actually will do a combined approach, unless the primary is symptomatic, and then in which case we may do the primary first. But in rectal cancer, this is a case where we often or consider liver first strategy. And the treatment sequences proposed is typically systemic chemotherapy, followed by the liver resection, then chemoradiation, and then the proctectomy. So that's generally the sequence when we use the reverse strategy for rectal cancer. In some cases, we could even debate as to what the role is of chemoradiation in this situation, particularly if there's a significant response to systemic chemotherapy of the primary tumor. So this is the liver first or reverse strategy that we typically recommend. Chemo first, 4 to 6 cycles. Remember, this is in a resectable patient. The goal is not conversion, as we spoke about this morning. This is a resectable metastatic disease. Short course of chemo, typically 4 to 6 cycles, 2 to 3 months, then the liver, then chemoradiation, then the proctectomy, and then completion with. But you can imagine, sometimes we may do the chemoradiation prior to the liver resection in selected cases, or we may do the chemotherapy in between these operations and end with a proctectomy. And then, of course, when you add the reversing of the ileostomy and other strategies, you can see this patient is expecting a year's worth of strategy, a year's worth of therapy, if you will, counting multiple operations and multiple strategies. Again, the goal is to try to achieve all those pieces of the puzzle in order to offer the best curative strategy. This question of reverse has been looked at. This is a study looked at first, published in France, a small study, 20 patients, suggesting that you can do liver first. Again, selected patients, there's the survival curve. This was also looked at this is a study from MD Anderson that looked at all the surgical strategies for synchronous liver and primary colorectal, and you can see Here, the reverse strategies in gray, the classic strategy in black. You could see over the years, increasingly, the reverse strategy still makes up about a fourth of patients who present with synchronous disease. The combined strategy you can see here, and the primary first in about a third. So you can see how this thing has changed. At Hopkins, it's similarly, we do reverse strategy in about probably as many as half the patients with rectal cancer, and we rarely do it with colon cancer. Here are the outcomes from the MD Anderson group. You can see comparing the combined, the classic, or the reverse strategy. No significant really difference except that the combined is less commonly. Major hepatectomies are done, but certainly it's an approach that's quite favorable in selected cases. And here you can see from their data the long-term outcome. No surprise, no real difference in these patients, not a randomized study comparing the classic, that is the colon first strategy, to the liver first strategy, to the simultaneous resection in these groups of synchronous patients. So when one thinks about what are the recommendations, as I've told you, I think in primary colon or rectal cancer that's symptomatic, one should think about addressing local strategy first, either resect the primary or chemoradiation or a stent or whatever strategy to address the local in the symptomatic patient. In the asymptomatic colon case, we typically will do chemotherapy first, but think about simultaneous resections in these patients when things are available. And in the primary rectal cancer that's asymptomatic, often chemotherapy first, but the surgical strategy, consider the liver first strategy in such patients. Here's a case, let me just illustrate a case. It's not always as simple as just reverse or not reverse. This is a patient who presented with a sigmoid colon cancer, and you can see here bilateral metastases, large metastases in the right hemiliver, as well as one in the left lateral bisegment and one small one in the medial segment. One can strategize, is this resectable, convertible, unresectable? And this patient had a sigmoid cancer actually that was symptomatic. What options would we think about treating such a patient? Well, what we did is multiple operations. Here's the approach we used in this patient. First operation actually was the left partial hepatectomy, partial resection of the disease in the left hemiliver, and I also did the right portal vein ligation, not embolization, but ligation at the time of the first operation, and a sigmoid colectomy. Then chemo, then a right hepatectomy, and then more chemo. So you can see the strategy of using staged approaches, portal vein ligation, and liver first strategy, not so much liver first, but combined primary plus the partial liver, and then the liver as the rest of the liver as a second operation. So just to give you a flavor of some of the complexities of how we use these different combined approaches in selected patients. So in summary, surgical strategies are defined by the classic combined or reverse strategy. Optimal timing of synchronous metastases remains to be defined but should be individualized. These strategies are associated with similar outcomes, and the combined strategy is considered safe with no different morbidity or mortality in patients compared to staged resections. Thank you very much for your attention.